Just by way of background, the health and social care structure within Northern Ireland, we have social care combined with health in Northern Ireland under the responsibility of our Department of Health, and when we have an executive under the responsibility of our Minister for Health. The Health and Social Care Board would be the commissioning service in terms of commissioning services from the 6 trusts and also from some of the arm's length bodies, of which my organisation, the Business Services Organisation, is one. The Business Services Organisation provides a range of services across the health sector, from procurement and logistics, legal services and IT services that I represent. In terms of our eHealth programme, the electronic care record had been a strategic objective for some time, and it really took the work of some very dedicated and enthusiastic clinicians to push this forward and drive this. Research began into how we could do this and what the potential options and solutions might be a way back 2008 onwards, to the point where we went live with a pilot in 2009-2010 time, and very successfully that pilot with Orion Health, we then moved to a full regional rollout in 2013 on the 4th of July 2013. So just last week we celebrated our 5th birthday for the electronic care record. The 5 health and social care hospital trusts make up the region, as you can see. Belfast Trust, they're in purple, is the smallest geographically but the largest in terms of workforce and population, and would host a lot of the regional services. The 6th trust is our ambulance service, so that makes up the 6 trusts within our region. So as I say, we're at the 5-year stage of our electronic care record as part of the eHealth programme, and I know that transformation word comes out quite a bit and can be sometimes overused, but I would say it really is applicable in this particular context, as you'll see as we go through this. So the problem that we faced is a common problem. Heavy reliance on paper-based clinical notes. Those notes were very specific to that particular hospital or locality. Clinicians would say sometimes the patient was in front of them, but the notes weren't. And when they did have the notes, they maybe weren't as complete and giving the full clinical picture as what they could do. So that was the underlying problem that we were seeking to address. There were, and they are, also a plethora of digital systems there as well, but again, they are very much bespoke, focused on one particular clinical area. So to gain a composite picture of the patient, the clinician would have to log in and log out of all of these systems multiple times throughout the day to try to build up that picture, so it wasn't an ideal scenario. So we had those multiple silent systems, we had paper-based records, we had fragmented records because of that. So what we needed was something to sit in the middle to pull all of this together, and hence the concept of the electronic care record came into being. Even with those digital systems, each trust or each hospital had its own instance of those as well, so that just compounded the problem. So we had to look at some way of interfacing all of those systems together and bringing the data into form one picture. So the proof of concept, we started off small, just 2 hospitals in 2 different trusts, and a small number of GP practices interacting with it. From the outset, we wanted this to be a patient-centred solution in terms of the patient their record was at the centre of it, and it had to be. It wasn't an IT system; it was a clinical system. The tagline, it's a system by clinicians for clinicians, was the vision that we had. as I said, we had that pilot proof of concept phase from 2009 through to 2013 with Orion Health, who then won the contract on the back of that to implement the full regional system. So in terms of I appreciate this is difficult to read, but we had 5 sort of core objectives within the programme, and delighted to say that those objectives were more than met, they've been exceeded. I think the success and the uptake of the entire programme was more than any of us had dared to predict. Okay, one of the key reasons for that was the governance around the whole programme and getting that right from the beginning, and there was sort of 3 core tenets of that. We had a very strong decisive project board with senior leadership, clinical leadership. We then had a strong information governance group, particularly around the area of consent was a big issue in those early days. We made sure that was addressed, and that critical component was covered off early on. And then the operational aspect of it was looked after by a clinical content group who would have decided on the local priorities and just driving that programme forward. And if time permits, I'll maybe play a little video clip later on where Dr. Clive Russell, who chairs that clinical content group, explains a little bit about the beginnings of the programme. In terms of usage, I'll just fly through some of these, but we have over 20,000 active users. That's users who have been active on the system within the last month or so. So it's in terms of penetration, it's been fantastic, especially across our clinical user cohort. So it's very much into that vision of being a clinical system for clinicians. Penetration has been fantastic, and uptake and growth is exponential. It just keeps growing and growing. We don't know where all the new users are coming from, where they've been before, but it just keeps growing. And also the number of logins continues to increase, so that shows us as well that it's a very active, necessary tool in the day-to-day running of our clinical services. Okay, just to cover off some highlights, there's a lot to mention, but just picking out a few of the main ones. We have a broad programme that we work to, so in the previous year we would divide that up into 4 sort of core areas. Integrations is always a big element of this. It's bringing the data in from those separate systems. Then there's a number of specific project-related aspects that we want to do within the electronic care record in terms of functionality that we're embedding within the ECR. Then there's the work that goes on with our primary care colleagues in terms of receiving information in from primary care and electronic document transfer back out into the primary care sector as well. And then there's the business as usual platform back-end stuff that we have to do to keep the system operational. The system is hosted by the Business Services Organisation. Okay, so some of the highlights over the last year or so, we implemented the eTriage electronic referrals element. That's been a great success. GPs can refer directly from their GP practice systems into secondary care. So this is an immediate referral in. It's fully auditable in terms of tracing that back through. So there's none of the delays that you would get with a postal-based referral system. We actually did a few tests where the GP did the electronic referral and at the same time also did a letter, paper-based referral. And typically what happened was the electronic referral was received, was triaged, and the patient had their appointment, in a lot of cases, before the paper version came and reached the consultant. So that, there's lots of that anecdotal evidence there in terms of the benefits that has brought. The radiology order comms, again, was another ease of use thing. So it meant that users within the ECR system didn't have to come out of ECR to order radiology tests. They could do that within the context, so they had the patient up in front of them on the ECR, and then they could raise an order for those diagnostic tests directly from the system. And again, you've got the full audit trail and traceability right through for that. So that reduced paper, saved time, and standardised process. Probably not the most sort of glamorous area to cover, but again, we put in functionality there to do our death notices, the mortality and morbidity solution within ECR. Very useful from a governance point of view, and tracing back and standardising that, again, standardising that process. And that's actually helped maybe push the way towards moving on from just a basic coroner service to maybe making the case for a wider medical examiner type function within our healthcare system. Again, in and around the governance side, results sign off, lab tests and so on are still typically paper based, and they would come through and would have to be or should be signed off. We have the facility throughout ECR to do the electronic sign off of those tests. So that would have, for example, helped with those learning letters produced around incidents where lab tests, positive lab tests had been received in. I think 8 different clinicians had looked at it, but no one had taken action on it. So by putting a little bit of process in around that and building that into the ECR, that has helped reduce those types of incidents. One of our laboratory managers in one of the trusts has referred to this as the holy grail of governance within his laboratory world. Again, it's just reducing the paper flow and the delays that come through that as well. Diabetes pathway, this has been a very long-running piece of work, very involved, very complex. It's allowed us to actually replace 9 different instances of the current diabetic management system, patient administration system, so that's been a great saving and a great efficiency as well. So it's, again, it's all under one place. That pathway is there. It's also moved us from just displaying data, as we would have been previously doing within ECR, to actually ECR is now a source of data as well. So it's shifted that emphasis a little bit. As I mentioned previously as well, data integrations it seems to be never ending. We're continually being asked to bring in data from other systems that are out there. We try to prioritise that and work through that. Obviously that involves working with the suppliers of those systems, trying to get common messaging formats and so on. So that's a continual, ongoing piece of work. So that those are some of the integrations that have happened over this last year. And again, with having the social care aspect within our health service, some of the information around our children at risk register and our looked after children and so on is now available through the ECR also. Key information summary. This was ECR was used as a way of displaying this, but this was initially a piece of work done with our GP colleagues. So people with long-term conditions would, in conjunction with their GP, complete the key information summary, and that would include what packages of care were available, just a little bit of information about the patient and their care network. It also includes their wishes around the end of life treatment and so on. So that type of information is summarised and easily available and viewable to all people involved in that patient's care throughout the system. Again, that's kept updated through the GP, and then those updates fed into the electronic care record as necessary. Medicines reconciliation. Again, this was quite a challenging piece of work. Pharmacy practice across the different trusts, as with most things, were different. They approached it in different ways. Pharmacy, by nature, is a very governance-led discipline. So a lot of work to get that right. We're challenged to some extent by the fact that the information coming from all our GP systems, we're not bringing across the DMND drug codes at present. That's being worked on. So in the interim, we're going to have to do a background mapping to codify the drug information coming in from the GP systems, so that can then be used downstream throughout ECR, ultimately then to feed into our immediate discharge summary that we're working on. So again, but to move away from the manual input of the current medicines reconciliation piece at admission, for example, is the big benefit coming from the medicines reconciliation functionality. I'd mentioned previously electronic document transfer. So this completes the loop, if you like, from the e-referral process from the GP practices into secondary care. This is secondary care sending information back to primary care. So the documents coming out of ECR are automatically uploaded into the particular practice system that GP is using. Again, just taking a lot of the paper out of the system. It's actually to the point where one of our trusts have completely stopped sending paper back to the GPs. So that's the aspiration of the remaining trusts. You can see there are some of the benefits for both the hospital and the general practice side. And again, it's around reducing paper, speed of transfer, and just general efficiency around that. We had no way previously of knowing, did the document actually end up with the GP, where now this is fully auditable and we can trace that back and make sure that it has been received. Okay, in terms of what's coming up, sometimes where we take ECR next feels a little bit like this. We get conflicting messages, and it's very hard sometimes. And this actually is a true picture. It has to be Ireland, somewhere in Ireland. I believe this. But sometimes we do feel we're being pulled in different directions. But again, that's partially a victim of our own success. People want more and more from it, but yet we have to sort of prioritise. We have only so much resource and capacity, so we have to prioritise where we go next. And that's where the strong clinical direction needs to come from. We do have as I say, a programme. So for the coming year, or for this current year, again, it's a bit daunting sometimes when you look at the length of that list, but we're working our way through it. We're ultimately guided by the original business case that we produced at the outset, so we're working our way through that. We're probably coming towards the latter end of this being an active programme and transitioning some of this into a more business as usual type operation. So following on from the medicines reconciliation piece this year, we're just about to go live with our immediate discharge summary, immediate discharge letter. Again, the medicines rec was a key prerequisite for that. So again, it's just reducing paper out of the system and trying to standardise process around that, and the speed at which then that information can be dealt with, so that again the immediate discharge letter can go directly from secondary care straight back into the GP land. Cross-border radiotherapy referrals. We've managed to achieve a frictionless border, Brexit or no Brexit, between the Republic of Ireland and Northern Ireland on this particular one. So maybe this is a model we could use. Patients up in the sort of northwest of the Republic of Ireland, Letterkenny, sort of Donegal, that area, for radiotherapy treatment would have to travel down quite a distance to Dublin. So what this enables us to do is the patients to receive treatment in Londonderry Galvin Hospital. So we receive their information from the sending hospital into the electronic care record. That then is updated in terms of their treatment that they're receiving with us, and then transmitted back again back into their own system in the Republic of Ireland. So that's a model that we intend to expand maybe for other conditions, and it could be the other way as well, services delivered on the other side as well. As I say, the data integrations piece is a continual theme that runs through. Some of the systems that we want to start bringing in include our information from our renal systems, our ED systems, digital retinopathy system, and more information coming in from our community systems. So rather than reinventing the wheel every time, we've just completed work on a generic interface specification that Iran Health are implementing, so that it's a specification we can give then to the suppliers of these other systems to say, this is the format, this is what we want to receive from you. And it means we just don't have to keep recreating that process every time. And there's just seemingly a never-ending list of integrations that we can do. In terms of feedback, this is where the strength of the system really is manifested. You don't have to go seeking positive feedback for the system. I think it's so owned by the clinicians that they think it's theirs, and it really is theirs. And you don't need to prod too much to get a positive comment back. So there's any number of these testimonials coming through, and some of our clinical colleagues would be the first to admit that they're normally not that effusive in their praise of IT, but in this case they really are, and it's always very rewarding to get that type of feedback. Probably the most over the top comment would have been from Professor Patrick Morrison in an article in the British Medical Journal. He said ECR was the biggest advancement even beyond DNA testing. So I'm not sure about that, but that's the regard that it's typically held in across our health service. In terms of next steps, where we're going with it, as I say, we're transitioning more and more of this from a program into a business as usual operation. We're looking through Orion to do upgrades to our actual the clinical portal element of it, which will bring some additional functionality around collaborative work lists and so on. Pathways is an area that we would like to take forward, but based on our experiences with the diabetic pathway, the length of time and effort that takes, we just have to be quite discerning around where we go with that. And then another very exciting development is our patient portal. This has been a core element of the wider HSC strategy for some time, and it's to empower the people to be more active in their own care and support. And it's a bit of an irony in some ways that the data, the person to whom the data belongs is probably the person who has least access to it within our system in terms of the patient. So this is to help address that, and it's to allow us to display some information to our patients, information that's already in our electronic care record. So we're starting off with a Pathfinder project aimed at a dementia cohort. Probably not the most obvious cohort to start with. It brings its own challenges. There was a number of drivers why we started with the dementia cohort, but we expect this Pathfinder will tease out a lot of those issues and will allow us then to start expanding into other cohorts. So by August, we're hoping to have around 100 patients and their carers live on the system in the first phase. Well, actually, just to cover some of the timelines, are some of the functionality that's coming with the patient portal. In phase 1 in August, they'll be able to view their previous and upcoming hospital appointments. They'll be able to have access to a health library, so this will be a trusted library of health-related information to their condition. Rather than relying on Dr. Google and trying to search through and find out what is real and what's not real out there, this will be properly vetted clinical information related to their condition. There's a shared files facility, so people involved in delivering the patient's care can share specific files with them, and the patient can in turn share information back with the healthcare professionals. And very importantly, within particularly this particular cohort of patients is our circle of care. So this is where family members or friends, relatives, whatever, can have the same level of access ultimately as the patient has, so they can help the patient navigate their way through the care system if needs be. Again, the governance around that is huge, and it's a very important factor that we're looking at. Phase 2 coming in April will allow healthcare providers along with patients to set goals and monitor progress along the pathway to achieving certain goals, and that whole range of different aspects can be brought in there. There's some predefined goals, and then there's the opportunity or the option to create your own goals as you go as well. Document services is similar to the health library, except this is where we are starting to bring actual clinical documents out of our ECR available to the patient. Hopefully most of our clinicians over the recent times are writing those documents in a way that is suitable for sharing with patients. But we're starting to present actual clinical data out of our ECR to the patient. And then phase 3, we've left to the end some of the more complicated and more challenging aspects of this. So we'll be displaying their current medications or their medication history, as well as diagnostic and laboratory results to them. How that is displayed is going to take some work. Some patients might just want to know, is everything okay after my blood test? Others, maybe diabetic patients, might want to have some of the detail there. So we're going to have to find a way to accommodate those different levels of users and their requirements. So that's a very exciting project for us. We expect that to take off very quickly, and there's already a long list of other conditions that want to be part of this as well. So finally, thank you for your time. If there's any questions, I'll try to answer them, but thank you for your attendance this morning. Thank you.